Well, why don't we get started? Welcome. My name is Jim Greenblatt, and founder and medical director of Psychiatry Defined, and really excited to present this webinar with a colleague, friend, and incredible person, Dr. Mariela Podolsky. July is summertime for many, but it's also for me, it's 7 years now, the beginning of our fellowship. And we've been training clinicians in integrative and functional medicine. We had our first session last night, and I think a few are on this call, and it's exciting. My career has been based on helping clinicians understand that there are other tools in our toolbox besides just medications. And so we have a fellowship starting. We're going to repeat last night's first presentation. So July is the general fellowship, and August is the pediatric fellowship. And this is our focus and our webinar. And Dr. Podolsky's particular talk is just going to be really helpful, I think, for those of you that are looking. And the title of the talk, Bridging the Gap, as we all look for ways to help our patients. So there are educational consultants available to talk with you to see if the fellowship is right. We have a few more weeks left, but we're fortunate to have Dr. Podolsky tonight to share her thoughts about bridging the gap and how to integrate integrative and functional medicine into a traditional practice. And I've heard the talk, and I know you will learn something. So pay attention, and we'll be available to answer questions after. So, Dr. Podolsky, you're on.
Thank you so much, Dr. Greenblatt. Thank you for having me tonight. I'm excited to be here. As Dr. Greenblatt said, the title of the talk is Bridging the Gap, Integrating Functional Psychiatry into Traditional Psychiatric Practice. I am located in West Hartford in Connecticut, and I have a private practice office. As many of you who are here tonight, I didn't start with a functional psychiatry background, and so that's what we're going to talk about, how this has come into my life. Thank you for being here. So, there you go. Okay, so I'm originally from Costa Rica. This is one of my favorite places in the world, in the Caribbean side of my small country in Central America. And this is my journey to integrative psychiatry. I did traditional training. I was trained at the University of Costa Rica. I studied medicine there. And after studying medicine, I worked in a remote area of the country for a few years before doing my psychiatry residency at the Institute of Living in Hartford, Connecticut. After completing a psychiatry residency there, I completed my child and adolescent psychiatry fellowship at the Medical College of Wisconsin, in Wisconsin, of course, in Milwaukee, and was trained, as many of you have been, and most of my colleagues, just in traditional psychiatry, mainstream learning the basics of and more advanced techniques too of how to treat psychiatric patients. When I look back thinking about this talk, when I first had to get the information together, I thought about the many days and nightmares about biochemistry classes and having to study this. This was my book of biochemistry back in the day. This is many years ago, probably has changed a lot. And I remember having to memorize these biochemical pathways from one molecule to the other, really meaningless. I didn't pay much attention to it, but however, this is what we were taught to do. And so we did it. And now looking back, this is so important and a big part of what functional medicine and functional psychiatry is. This is the hospital where I did my child and adolescent psychiatry fellowship, the Children's Hospital of Wisconsin. And I remember very clearly this question that later on, when I learned more, haunted me. One of the doctors in adolescent medicine had placed a consult for a patient, and she came and asked me point blank, like, why do you think that some kids respond to fluoxetine 10 milligrams a day and others need 60 milligrams a day? And in my very significant lack of knowledge at the time, my answer was something along the lines of what I had been taught, which was, I don't consider that giving somebody fluoxetine 10 milligrams a day is appropriate when the effective dose is 20 milligrams. So if you're going to prescribe a medication to somebody, you should prescribe a medication that is known to be effective at a certain dose and go with that dose in particular. Little did I know that I would be swallowing my own words. And years later, I search her up. I obviously have no contact with her since that time. This is many, many years ago, but I searched her name up and called her and said, "Hi, this is Mariela, and I don't know if you remember, but now I have the answer. Why some people respond to 10 milligrams and some people need 60. And that is genotype testing, something that you can learn to do in functional psychiatry. When you look to UpToDate, and I don't know about you, but I use UpToDate for a lot of things. I find it to be an incredibly useful tool that has updated treatments and information, scientific, evidence-based. It's an excellent resource to learn about any topic in medicine. And so I put there what to do for depression. What is the treatment for pediatric depression? And this is what I found. The initial treatment depends on illness severity and duration, the presence of agitation, psychosis, and whatnot. It really didn't tell me much, but it did tell me, well, let's try to choose a medication. And then what it told me on top of that was, okay, so fluoxetine is first line pharmacotherapy for depression in adolescents, and you should use fluoxetine unless you want to avoid specific adverse effects, or you had a better response to a different depressive episode, or maybe a parent or sibling had done better in a different antidepressant, or you have an allergy to fluoxetine, then find something else. It really didn't tell me much about the uniqueness of my patient that I would have in front of me, or what other things I should be considering. The reason why I bring this up is because I really respect UpToDate, because I can find a lot of information in it that is helpful and that has geared me towards a better outcome in my patients' treatment plans. But it is incredible to think that in a big platform like UpToDate, this is the only mention of treatment for depression is fluoxetine as first line, and no other considerations. After I graduated from my fellowship in 2012, I had to work in an underserved area in Connecticut in a child and adolescent psychiatry clinic, where I saw patients like many of us for 15-minute med checks. One patient after another was extremely tiring. I felt like I had the weight of the world on my shoulders. I felt like I couldn't solve anything. I found it to be incredibly frustrating, and my patients just did not get better. I didn't have the knowledge, and I really didn't have the resources, but more importantly, I didn't know what I didn't know back then, and it was incredibly exhausting. My career has always been, I have a particular interest in eating disorders, and I have worked with eating disorder patients in all levels of care. So here are the three aspects of my career before I have kind of navigated the world of integrative psychiatry, but I have been an adult psychiatrist. I'm board certified in adult psychiatry. I'm board certified in child and adolescent psychiatry, and I have worked with eating disorders in the Academy for Eating Disorders for many, many years. It was not until 2020 that I decided to do the fellowship for Psychiatry Redefined, and I discovered a whole new world that has really changed my career for the better. In that fellowship, and if you are in the fellowship or thinking about it, one of the things Dr. Greenblatt talks a lot about is the zebras and how every zebra is unique, and there are no two that are the same. And it's similar to what we see with patients. There are no patients that are the same. Starting everybody on fluoxetine falls short when we're talking about treatment for depression, because there are so many other things to consider. I am a firm believer that my prescription pad is still active. I still prescribe medications of all types, including antipsychotics and stimulants on a daily basis. However, my approach is now integrative, and integrative is called integrative for a reason because it combines both traditional psychiatry and what we call as functional psychiatry. And I heard this statement the other day: what is functional medicine? The medicine that actually functions is what I heard. So I love that statement, and I think it has been very true for myself and for my patients. So I'm going to just walk you through my journey with cases. Before I move on, I think the biggest thing that happens to all of us is we are paralyzed with fear because we don't know enough about functional medicine or integrative psychiatry, and we don't know where to start or what to do. So this is in 2012. This is the first patient I'm going to talk about. She at the time was a 17-year-old woman with anorexia. She had been weight restored for a period of time. She continued to have depression, having a lot of difficulty engaging in activities with friends, her social life and school, a lot of anxiety, paralyzed by fear. And she was already on medication. She had been prescribed escitalopram or Lexapro, 20 milligrams per day, at least for a year. And even though she had had some response, it wasn't fantastic. So I didn't know this was functional psychiatry, and I didn't know really that this was going to be life-changing in terms of my professional approach, but I had ordered genotype testing, mostly because somebody told me that maybe this could offer some solution to my patients. So I kind of wanted to drink the Kool-Aid. I don't really have any other explanation, but that's what I did. And in that genotype testing, I learned that she was what we call an ultra-rapid metabolizer for the cytochrome P2C19, which metabolizes escitalopram. And she had an MTHFR mutation she was homozygous for the TT mutation. What did that mean? It meant that her escitalopram dose, even though she was maxed out based on the FDA approval, she was metabolizing it so quickly that her serum level was probably not building up to therapeutic effect. And so we decided to increase the dose to 30 milligrams of escitalopram, which was above the FDA approval. And I added what I thought at the time was a good idea. I added 15 milligrams of methylfolate. Thankfully, she did incredibly well, and she improved significantly. And for the first time in years, she came back and told me, I don't know what you did, Dr. Podolsky, but I feel so much better for the first time in years. This is integrative psychiatry in a nutshell. 20 milligrams of escitalopram wouldn't be enough for this particular patient because her genetics were different. She was a different zebra, to say it in some way. So I'm going to walk you through some of my cases that I have throughout the past few years of this journey, and I hope you learned something from them. This is Henry. Henry's a 16-year-old, and he came for the first time to my office with the concern of tics. They had started about a year ago, and then they went away. They were in his face, sometimes on his neck. It had been worsening, and they had been happening every day. At night, it was worse. There was some anxiety. He was starting to have some social concerns. He didn't have any significant mental illness otherwise. And, overall, he was in a good place. And so what did I find when I ordered some labs? So this is what I found: just a very mild, not very severe vitamin D deficiency. And that was about it. So my treatment plan for this young man was to add magnesium glycinate, starting at a lower dose, but increasing it to 240 milligrams a day, and a vitamin D supplement. He had complete resolution of symptoms within 3 weeks of him starting the magnesium. which was incredible. I was blown away when I had these results, blown away. And he went away for a vacation to Florida. And when he was there, he stopped taking the magnesium and his tics returned. So he came back to my office and said the tics had come back. And when I explained, when I asked him to explain the timeline, it was really evident that he had stopped the magnesium and they had come back. So what happened? We restarted the magnesium again and told him, you know, Henry, this is actually something that you might have to do for a very long period of time. But this is your solution. He discharged from my practice a few months later with absolutely no symptoms, no tics, and doing excellent. So with that, I bring you back to this. In my fellowship, and as I said, I'm a board certified child and adolescent psychiatrist. What I learned in my fellowship is that we should be using medications like clonidine or guanfacine to help with tic disorder. And that's what I would have done had I not had this knowledge. In my opinion, if this were my child, of course, I would prefer to do magnesium than prescribe them clonidine or guanfacine to help with the tics. Simple case, simple intervention that made a world of a difference for this patient. Let's talk about Anna. Anna came to me slightly after the pandemic, like maybe shortly after the pandemic. She was 13 years old. During the time of the pandemic, like many adolescents, she really struggled and she developed an eating disorder, had been in a better place in terms of her eating and her weight. And she had been struggling more recently after she had already semi-recovered, to say it in some way. She came to me with a lot of sadness. Everything felt like a waste of time. She was crying a lot. She was not engaging in things that she used to love. She was tired with no motivation, feeling hopeless and worthless. Her appetite had been normal. It was really not related to her eating. And she felt anxious all the time. She was not on psychiatric medications. And as I said, her treatment for the eating disorder piece was kind of completed and she was stable from that part. Her labs showed a zinc level that was less than ideal, but not super low. Her vitamin D was slightly low, and her MTHFR, again, just like Megan, my first patient, she had a homozygous mutation for that gene, and she had TT. So what did I do for her? This was my treatment plan. And by the way, these are copies of my electronic medical record, exactly how that was documented. So I started her on L-methylfolate 5 milligrams per day, a vitamin D supplement, fish oil, and a multivitamin, and zinc because her zinc was less than ideal. She came back in 2 months, and mom used these words, "It is like a miracle," quote unquote. She had returned to her after school activities, mood had improved, fatigue had lifted, she felt her self-worth had restored. She no longer was crying. She was no longer crying, and she was in a much, much better place, which is incredible. I didn't prescribe fluoxetine like UpToDate would have told me. All we did was supplement her and particularly treat her MTHFR mutation. This is John. John is my first hair mineral analysis patient. So he's dear to my heart because he taught me a lot. John is 10 when he came to see me for the first time. He has a history of being adopted when he was 3 months old. He has a binge eating disorder diagnosis and had been in treatment for a long period of time, almost a year, between intensive outpatient and partial hospital programs. His weight was close to 250 pounds, even at 10 years old. He had ADHD with significant inattention, difficulty with academics, distraction, losing items. Parents needed to repeat things over and over again. So when I saw him, my initial treatment plan, because I had not yet learned about functional psychiatry, was Vyvanse and Pyramid or Topamax, which are both medications that are used for binge eating disorder and also that would treat his ADHD. Don't get me wrong, he actually did improve some. He got better. However, 6 months later, parents are coming back and telling me he's very disrespectful, aggressive towards his parents and his younger brother. He has irritability, explosive episodes. He's having even behaviors that were very impulsive in the way, like stealing from his parents. Had at that point identified with the gang culture. It was slight disaster, to say it in some way. All of his labs were normal except he had a low vitamin D. So what did we do? Well, we did a hair mineral analysis, thankfully, and you can see here that I learned, one of the things that I learned is this imbalance between copper and zinc, and how copper can be really contributing to his explosiveness and irritability, ADHD symptoms. And the other thing that I learned was that he had very low lithium level in his hair. So what did we do for him? So for him, we did Vyvanse, as I had said before, Topamax. He was also on trazodone for sleep. And we added lithium orotate, 5 milligrams, vitamin D3, I was correcting that already, and zinc picolinate, 30 milligrams twice a day. The parents called me maybe 2 months or 3 months later, like when we met. They called me actually before that and said that the report was that he was so much better. It was so incredible that his waiting list for PHP was no longer needed. He was in a much better place. He can be at home. And I remember participating in his PPT meeting at school and hearing the parents rave about how zinc and lithium supplements over the counter had made the difference and nothing else had made for this young boy. This is Frank. Frank is a 16-year-old male. He had been attending boarding school. He had been treated by a different psychiatrist at the time when he came to see me. Since young, history of depression and anxiety, a lot of difficulty with transition, question of autism being present, we didn't know. He had a diagnosis of ADHD and major depressive disorder. There was so significant social anxiety that he had to leave school and come home. So much distress, he had suicidal ideation. Panic attacks were present. He was already in psychotherapy, and he had been on medications for years. Like, he came to me on multiple medications. During his evaluation and the lab slip that we got, like just the basic labs, this is what I found. He had a homocysteine level that was elevated to 53.5. That is my personal record, and this is why I put it up here. I've heard of levels that are significantly higher than that, but this is the highest that I have seen in a patient of mine. I work mostly with kids, so that might be why. And his cholesterol was very low at 112. His MTHFR status, he had homozygous mutation as well. So we continued the medications that he had been on, fluoxetine and Abilify and Concerta. He had been on those medications before, but I did add fish oil and homocysteine factors for him, to hoping that I would be able to decrease that homocysteine level. And what happened? Well, 4 weeks passed, which is not a lot for a kid who's struggling so much. And he was so much better. He could return to boarding school. He continued to have some anxiety and some anxiety and needing psychotherapy. However, he no longer had suicidal ideation, and he no longer was having panic attacks. And what was our goal with him? Well, he was a work in progress. It didn't happen overnight, but he did get better. And we have been able to reduce pharmacological interventions over time, less and less. He still needs a stimulant, and he still is an antidepressant. However, his symptoms are significantly improved. And till this day, we continue to monitor his homocysteine levels. And he continues to take the homocysteine factors supplement to keep his levels in check. This is Mary. Mary is 12 years old. She has a previous diagnosis of ADHD and generalized anxiety disorder. Over the past few months, she had been engaging in extremely risky behaviors, being very irritable, conflict with her parents, impulsivity present to the point that she actually got out of the house in the middle of the night at the early age of 12 to meet with some young man. Parents are extremely concerned about this girl. It's a big change from baseline. Academically, she's struggling. Socially, she's struggling. She has been in therapy, and she comes to me already on medications. She had been on citalopram 20 milligrams per day, and amphetamine salts, so Adderall for 20 milligrams per day for multiple years. So she comes to me, and we do some basic labs, and this is what I find. A zinc level of 69, knowing that that is less than ideal. A B12 of 384. And this is important because Quest reports the normal B12 level, pardon me, between 260 or 900 and 935. Sometimes the range is like 200 to 1100, something along those lines. However, at the same time that they say that, they say, oh, by the way, if your patient has a level that is between 200 and 400, they may experience neuropsychiatric symptoms. So I truly do not understand how these two particular things can be true at the same time. I think either your level is optimal or it isn't. So anytime that I see a level that is less than 500, I do suggest a supplementation with vitamin B12. And that's what we did for this young girl. And her vitamin D was evidently low. We also obtained a cryptopyrrole exam, and if you're familiar with that. So what did I learn from cryptopyrrole was elevated, and what that tells me is that she is wasting away vitamin B6 and zinc. And so what do we do with her? So initially we supplemented with B12 and D because those were the labs that I had. I did add guanfacine. Again, I'm a psychiatrist after all, and I use my prescription pad. So I did add guanfacine extended release to help with the impulsivity, and actually that helped some. But really what helped was adding zinc and vitamin B6 for this girl. This is a couple of years ago. 3 months later, then she had significantly less impulsivity, decreased irritability, and conflict with her parents. And I'm happy to report that right now she is no longer on the guanfacine. She continues to take her Celexa and Adderall. But we have repeated the cryptopyrrole, and it's interesting. It is, even though she continues to take the zinc and B6, it's just right there, borderline normal, right? Like it's probably 9 or 10 with the supplementation of zinc and vitamin B6 and now magnesium too. And so what I have learned about that, again, the individuality and everybody's different. I don't know the reason why, but she is somebody who needs the supplements more than others. And when she takes them, she does so much better. And her parents notice it, she notices it, and she feels so much happier when she is taking her supplements consistently. This is a fascinating case because I think it is very telling, not only for psychiatry, but also for primary care, how important these interventions can be. This is Adam. Adam is 60 years old, and he has a diagnosis of major depressive disorder, recurrent, severe, many, many years of treatment, psychotherapy, a very difficult life with many significant stressors with his son, who struggles a lot. And he has been on bupropion for 450 milligrams per day, which is the maximum dose of bupropion. And so in what he comes and tells me is, I don't know what happened, but in the past 6 months, he was unable to get his day started. He just could not get going. He is a contractor, and so he builds things, and he's extremely active physically. And he would just sit on the couch, being unable to get up and do what he had to do, delaying his work for hours, had lost joy in things that he enjoyed doing in the past, felt extreme guilt, passive suicidality, just catastrophic thinking, a lot of pessimism and hopelessness, and his fatigue was beyond his normal. He felt really ill by all of these kind of very vague symptoms. And this is what we found. His vitamin B12 is 239. Again, with a disclaimer from Quest that that's normal, but it isn't. Homocysteine level was elevated, and we know that homocysteine elevates when there is a functional deficiency, vitamin B12 or folate. Also, oftentimes it's related to the MTHFR mutation. Vitamin D was also low. And so this is what we did for him. We continue the Wellbutrin, 450 milligrams. I started him on B12 shots. There is a compound pharmacy and found it, and of methylcobalamin, and they sent the shots for him, and he was doing 3 1 milligram shots every week for his significant B12 deficiency. His vitamin D3, I started supplementing that too, fish oil, and also added inositol for sleep because he was having some difficulty there. It was so drastic that he called me later, maybe a month later, and said, I feel an immediate difference when I get my B12 shot. It's almost every day that I get it, it's immediate in my energy. And I think this is really important because it's not only a psychiatry patient. I mean, he was presenting with what he thought was depression, but I think in reality, this B12 deficiency had some very physical symptoms that were also missed by his primary care because the range was within normal level. And I'm so happy that he came and we found this because he, till this day, he is doing very well. He no longer needs the B12 shots, but he's doing very well, and we check them consistently every so often to make sure that he's not dipping. He improved significantly. He went back to his baseline, no change in his environmental stressors. His life is still really stressful, but he was able to overcome this very well. This is Charlie. Charlie is not such a hopeful story. He's 26 years old with previously diagnosed schizophrenia, paranoid type. His parents come to me really desperate for answers and solutions. He had 2 previous inpatient hospitalizations. At the time when I met him, he had been working at a supermarket, which was great. He was able to hold a job. He was on clozapine at the time. He had a vegan diet for years. He also didn't eat any gluten. He had cut out gluten from his diet. He had paranoia at baseline, negative symptoms that were very clear: abolition, blunted affect, alogia. He was the very classic description of schizophrenia. Delusional thinking regarding conspiracy theories were present at all times. And every now and then he would be responding to internal stimuli. So his clozapine was holding him together just fine, but not good enough to be without symptoms. And this is so after talking to the parents and talking with Charlie, we decide to do a functional assessment, and he's willing to do this. And this is all that we found. So he had a very significantly elevated HPA that I know was contributing to his symptoms of psychosis. HPA prevents the breakdown of dopamine for those of you who haven't done the fellowship yet. And this is secondary to an imbalance of like Clostridium, one of the Clostridium bacteria in the gut. And with this elevation, patients can present with a slew of symptoms, one of them being psychosis. And this was present. We found that his cryptopyrrole was borderline at 1193. And this is incredible when we think about his hair mineral analysis. The profound malnutrition of minerals that this young man had in every single mineral that is listed here, he had less than ideal levels, which is very significant. I don't think I've ever seen any other hair results like this. Unfortunately for this man, it was too late. We recommended starting a regimen of supplements to treat his deficiencies and the elevated HPA. Also, I tried very, very hard to advance his diet to, instead of vegan, being vegetarian, and hopefully encourage him to start consuming animal protein to really treat some of his deficiencies. However, he was so psychotic at the time and his delusions were so severe that he was unable to comply. Unfortunately, he ended up being hospitalized again and had to discharge to a more intensive setting. And so I haven't seen him since. The parents were incredibly disappointed, not in me, but in the system and how we have missed something so important. Just sad that we didn't know. I wish I had known better back then when. This is Laura. Moving on. Laura is 12 years old when she presents to me for the first time. This is during the pandemic years, and her initial diagnosis is emetophobia. She has had weight loss due to distress. Eating around others is really hard. This girl wasn't able to watch a movie where there was somebody vomiting. Like, she immediately would get in distress. She had social anxiety, wasn't able to stay in class. Like, just the idea of somebody getting sick was so much for her. She had isolation. She was having panic attacks, classic textbook panic attacks, heart palpitations, sweating, nausea. And there was one thing with this girl. She had an extreme fear of needles, and her parents could not afford doing any of the functional testing. So I didn't have lab tests, and I didn't have any of the functional tests. So I did what my training had taught me, and I prescribed sertraline, started at a dose of 25 milligrams at bedtime, and optimized that to 100 milligrams at bedtime of the sertraline. There was improvement. I'm not going to say there wasn't. She now can eat in the cafeteria. She can participate in class. She's able to see some friends, but she continues to struggle with anxiety and heart palpitations and the sweating. 2 years pass, and at the age of 14, she finally agrees to obtain labs. And so with that said, and we obtain her labs, and so I knew in my head that I had one opportunity for testing. And so I decided I was going to test everything that I could think of. And I tested her for everything I could think of. And this is what I found. So her vitamin D was low. Her vitamin B12 was low. Her ferritin was low. She was significantly anemic, iron deficiency anemia. And she was positive for celiac disease. This was a shock to me. This was my first patient that I learned had celiac disease. And so that was a game changer. Well, of course, she had to go gluten-free after having the celiac diagnosis. We worked on lowering the dose of sertraline. That was part of what she wanted. But here's the thing. After she went gluten-free, she had minimal to no anxiety, no panic attacks, no heart palpitations. Her iron was normalized at that point. I think that also helped. No nausea, able to go to school, stay in class, see her friends. And this was all because we eliminated gluten in a patient who had celiac disease. Please note that she had no diarrhea and no stomach cramping. She had nausea, but she didn't have any of the cramping or diarrhea that we would classically look for when we're thinking of celiac disease. Since this patient, I added celiac panel into all of my patients when I first see them. At the time when I did this presentation for the first time last year, I had about 300 patients in my private practice. And in a year, in exactly 1 year, I had, no, not even, in about 9 months, I had diagnosed 8 new cases of celiac disease in patients that had different psychopathology like OCD, ADHD, PTSD, that had absolutely no gastrointestinal symptoms, no diarrhea, no abdominal pain. And all of them have improved symptomatology once they went off gluten. Some of them better than others, but definitely all of them had some improvement. Lyme disease. So this I added a little bit later on into my psychiatric evaluation. I live in Connecticut, so there's a lot of Lyme disease here. It's an easy blood test. And the reason why I decided to add it was I had a patient who came to me with anxiety. And I tried different psychopharmacological interventions. I wasn't the first one, but nothing worked for this kid. And I also see the sibling. And so a few months later, when I asked about this kid, the mom told me he had Lyme disease all throughout. And I didn't know that. And I felt terrible that I had missed this. So I started adding it into my panel when I'm looking to evaluate a new patient. So I'm going to present to you this patient called Richard. So he was referral from a local therapist around here. He has a diagnosis of Tourette's and ADHD. And during his intake, his tics and stuttering were so bad that he was not able to complete one sentence, like not one sentence without interruptions. He had vocal and motor tics, both of them. He's very self-conscious. He's very overwhelmed in social settings because of the tics. And the ADHD symptoms are present but are mostly academic. Anyhow, these are his labs. He's positive for Lyme disease. And it's not an acute infection. This is an old infection. His IgM was negative, but his IgG was positive. He had more than 5 bands, which is what you need for the diagnosis. And when I asked the mom, when did he have Lyme disease? Mom said he has never had Lyme disease. And we said, like, oh no, he has Lyme disease. So this was a new diagnosis for him. I also found an MTHFR mutation. He had a mutation in both genes, heterozygous, but he had one in both of the genes. So what do? I sent him to the pediatrician first. I said, you need first to treat Lyme disease. And so they treated him with doxycycline for 10 days. And at that point, his tics decreased by about 50%. It was incredible. At that point, we added L-methylfolate and magnesium to treat his tics and correct his mutation. And this is what I got from the parent just a couple of days ago. As a parent who is very invested in my child's well-being, I want to explore options. Once we incorporated the methylfolate and magnesium supplements, both our therapists and psychiatrists noticed a drastic change in my son's tics and movements. Most importantly, my son could feel the difference and told us so, especially when he missed a full day of vitamins to prepare for a urine test for one of the doctors. This is the cryptopyrrole test that I asked him to get. He had trouble falling asleep that night and told us he could just feel a little difference and didn't like how it felt. Incorporating these vitamins has made a huge difference for my son, and I am so thankful to currently not be on any medication for his ADHD. An incredible story. I'm very proud of this case, and the parents are really happy, and so is the kid. His improvement is so drastic, it's unbelievable. I think this is my last case. This is John. John is a 15-year. I work at a couple of boarding schools here in Connecticut. So John came to us from Washington. He's 15 years old. He's attending boarding school, and he does have a history of anxiety. He had been prescribed Lexapro for the past 6 months. At school, all of a sudden, he becomes increasingly unmotivated, disinterested, really having a hard time with everything, very sad, very isolative. Parents think that he is very depressed. They went on a vacation break and for winter break, and they were super concerned. Now when he comes back after winter break, he's skipping class, he's failing academically. Very significant change for this boy who previously had never had so significant issues. One day he comes to guidance counselor and he makes a suicide statement with a specific plan. This is an emergency, of course. So everything happens and his parents come and pick him up and bring him home to Washington. He's hospitalized for 2 days, where he started on Prozac, and then he's followed by intensive outpatient and outpatient therapy. The family connects with me because they want to start treatment. I am here in Connecticut and he's in Washington, so I can't really treat him. But I order his labs. I said, let's start with the labs. It's a Quest order. That's it. And these are the results. Well, this kid had Epstein-Barr Bar virus, meaning mono, for this whole time. It was overlooked. Nobody thought of it before. And his symptoms of fatigue and feeling unmotivated and isolative and tired and disinterested were explained by him having mononucleosis. And so when I learned this, I coordinated with a psychiatrist back home, of course, and the treatment plan changed significantly. There was really not much that we could really do for him because mono is mono, and like we're just gonna have to wait. But both the family and patient felt incredibly reassured and relieved by this finding. And he was able to return to school within 6 weeks after his suicidal statement and able to complete the school year without any problems. Still on the Prozac 10 milligrams, but really doing very well. So any case, those are all of my clinical cases that I wanted to share with you today. I often get this question, what can you order that is starting point? And this is where I think this is super important. Genotype testing I order genotype testing for all of my patients. Medicaid and Medicare covers it for those who have Medicaid and Medicare. They have like a sliding scale for patients who need some support with finances for that particular test. And for every patient, these are the tests that I order. CBC, iron, Epstein-Barr, Lyme disease, vitamin D, lipids, comprehensive metabolic panel, vitamin D, celiac disease, homocysteine, thyroid, and zinc, and magnesium. And that can be done by anybody, anywhere. Like, you don't need to have fancy functional tests, though those are helpful too, but this can be done by anyone. There are helpful and available interventions that are simple, that are little. Simple lab order can help identify what is the uniqueness of that patient in front of you and how you can help them best. I use this quote, and you can repeat it if you want it. When I'm trying to explain to patients, why am I ordering labs or doing extra testing? Your neurotransmitters are created similarly to baking a cake. If when baking you add only 2 eggs instead of 4, or if you add half a cup of sugar instead of a whole cup, you can still bake a cake, but it just won't be a good cake. I think this is an easy way to explain why all of these little things are important in the synthesis of neurotransmitters. And here, all of these vitamins and minerals are the ingredients for your neurotransmitter recipe. And so that's why we need to know what the numbers are. That has worked very well for me. I want to remind all of us, because I work with eating disorders, I was acquainted with this beforehand, but this is really important. For those who have plant-based diets, meaning vegetarians or vegans, they're going to be low automatically in iron, zinc, and vitamin B12, unless they are supplementing for it. So it's even more important to check for those levels. One thing that I struggle with in my world is that compliance is a major obstacle. When we start adding supplements, and there's a big array of supplements that can be provided to these patients. For these patients who are on many supplements, compliance can become an issue, particularly in the younger patients or the adolescents mostly. So it's important to prioritize what are the major needs and evaluate like the patient's ability to maintain that compliance, because really doesn't work out like if the patient is unable to take them. It might be that you only choose 3 things to work with instead of the 10 that you see in front of you. Then retest and prioritize the regimen maybe every 3 months or every 6 months. I offer additional testing to everyone, but not everyone wants to get it done. I do the blood work and I definitely do the genotype. Some patients refuse to do even that, but most of my patients have those 2 things. So am I an integrative psychiatrist? Well, I don't know. This is a learning curve. This has been a journey for me. I started small and I'm going bigger and bigger. I think anybody can do it if we start with little things, vitamin D, vitamin B12, zinc levels, et cetera, as I explained to you in all of my cases, simple interventions that make a difference. You can go slow. You will learn more as you gain more experience. Be patient. I would say this is new information. We didn't learn this during our training. Find your people, ask questions. Psychiatry Redefined has tons of support in terms of you can ask. You have some tutoring, some groups, some colleagues that you can meet along the way, and that it's very helpful. Going back to after what I have explained to you in all of those cases, this is why Up to Date seems to be so short when it talks about depression. This cannot be our answer. I just cannot believe that this is the recommendation that we give physicians or nurse practitioners or any other clinician that is working with patients when we're talking about depression, when there are so many other factors that are important. To almost finish, I said I have seen the light. And once you have seen the light, it's really impossible to go back to the way that I was practicing medicine beforehand. This has changed me forever, and it has changed the lives of my patients even more so. And my encouragement to you is with this phrase by Yoda, do or do not, there is no try. It's not too late. You can start little and build from there. You can do it. It has been an absolutely satisfactory journey that has changed the outcome of many of my patients. And I think that's my last slide. And here is another slide with the fellowship. If you're interested in learning more about the fellowship, you can schedule a one-on-one call with educational consultants. I think that we have still some spots left, not many, and there may be some limited scholarships, something to think about if you're interested. And with that, I finish. And I can open for questions. So
Dr. P, are you seeing in the Q&A?
I can see the Q&A, yes. Let me see. I have a lot of questions. Let me see what I can find. Okay, let me see. One moment. So, pediatrician. I'm sorry, there's a lot of hellos, which is great. I see people from all over, so that's fantastic. But I don't see questions so far. I'm going down the list. I'm so sorry.
Mariella, are you in the Q&A section? That's for you.
Maybe I'm not in that section. Oh, there it is. Thank you so much. I found
Sections are isolated for you, okay?
Yeah, I got it. Cholesterol so low, any of the prescribers meds to blame? I wouldn't think so. There are sometimes it's intake, sometimes it is the fact that some people produce less cholesterol. Cholesterol is really important for our brain functioning, and so it is important to normalize cholesterol levels. That's hard to do, but one of the things that can help is eat healthy fats, of course. Digestive enzymes can help, and maybe some fish oil is also important. What is the value of testing homocysteine as opposed to just checking a B12 and folate level? Well, so not every time that a B12 or folate level are low, you're going to have an elevated homocysteine, and there are multiple times that I have seen a B12 and folate levels that are within the normal range that the homocysteine is significantly elevated, and that happens because that is a reflection of a functional deficiency of B12 and folate. Let me see. What tests for deficiency would you recommend for a 12-year-old boy with ADHD and anxiety? Well, that is a long list of tests, but I think, as I said, I would start with the ones that I suggested. In my office, everybody that gets in the office with for an evaluation gets that lab slip and the genetic testing. That would be my first step. And then again, like the zebra, we have to really make an individual treatment plan for that particular patient. What codes do you use when ordering the lab so that insurance covers it? There's many different ones, but typically vitamin D deficiency, B12 deficiency, nutritional deficiency, sometimes depending chronic fatigue, white TSH with reflex versus TSH and standalone free T4. I think as long as you're testing TSH like the thyroid, it definitely, you can have your preference on that. Do you use also free amino acids? Another question. Yes, I didn't discuss that, but yes, that certainly can be very helpful. There are some other tests that are more advanced and like to checking for amino acid levels in blood. However, that we didn't talk about that here. Let me see what else. I think, what are the best sources for recommended supplements? There's many. There are many. I tend to choose one, and the one that I choose pure encapsulations, and I go with that. But there are many. I think you can ask around depending on where you are. If we're not ready for the full fellowship program, can you recommend where to get started in functional psychiatry? That's a great question. And what I would say with that is that's a difficult one, right? I think I don't think that I personally could have done what I have done without really going through a fellowship that would teach me the concepts of functional psychiatry, because nobody else did. I don't feel like I am a very good individual learner, meaning that without the structure, it would have been very difficult for me. But I think there are some, for instance, there are some webinars here that are available. There are also some programs that are intensives. Psychiatry Redefined is a great, I obviously did the fellowship, but I'm obviously talking here, so I'm a firm believer in this program. It's fantastic. As an ex-fellow, I can tell you it has changed my life, truly, and the life of my patients. And so there may be not full fellowship programs, but there are, like right now we're doing an ADHD intensive, and there are others. So maybe that would be a good option for you. I think
Dr. Bedell,
that's yeah.
one thing to mention for everybody. If you aren't ready for the fellowship and you want to put your toe in the water, schedule a call, because we're education consultants that will help you figure out the right path for you. It's just important to take the first step and begin changing the lives of your patients and your satisfaction with your practice.
Mm-hmm. So, yeah, I think what, let me see what other question might be. Do you have anyone who might do clinicals for nurse practitioner students? We get that question a lot. I don't, but I'm sure there are some out there. Yeah, there is a question here, Cindy, that you may be able to answer. What is available for nutritionists?
We have
I think
in the fellowship, and we have the introductional to nutritional psychiatry, lots of courses. Again, schedule the one-on-one call. That's why we have them. They're a gift to talk to you about your career goals and what matters to you, and help you set out to participate in the right courses for you. But we have lots of nutritionists. We have lots of pediatricians taking the pediatric fellowship. It's the first of its kind. So schedule the call. There's plenty of times that I've mentioned it on the side. And and learn about what's probably best for you now.
Yeah. I think we have good information here.
Yeah.
Let me see if do you need I'm gonna share once more. So the QR code is there.
Yeah. And I've put I've put the number in here for everybody, but thanks for joining us. We love doing these fellowships. We love doing these free fellowships a couple times a month, and the goal is for you to learn and to be able to have more to offer your patients. And certainly Dr. Podolsky has shared many, many, many reasons why becoming educated in blending traditional and functional integrative and nutritional psychiatry can make all the difference in both your career and obviously the lives of your patients and your future practice. So thanks so much. Everyone will receive an email tomorrow with a link to the presentation today. So look for that. Everybody who registers gets it. So with that, thanks so much. And we look forward to other webinars in the future. And Dr. Podolsky, you're the best. We love having you come. Your case studies are so easy to understand, so honest, and it's just fantastic to work with you. Thank you.
Thanks to you. Great opportunity, and thank you everybody for being here. You won't regret it if you are just thinking about the fellowship or just starting to read about it. I hope you join us for more, and thank you so much. Have a great night.